Next, I'm just going to go over a couple of the miscellaneous, and these is almost like a word play on some of the codes, and others have included, are now included in the billing for 2012. In the past, in 2009, when Medicare first came out with the code 93351, it was not recognized if it was performed at the hospital setting or a facility setting. Well, this year they decided to go ahead and start recognizing it. So if the same physician is doing the complete stress echo, the supervision, the report, all of that, we're now going to be able to bill the 93351 with the 26 modifier. Now, however, on this, if one physician does the stress portion, supervises that, and you've got another physician that's just going to be doing the interpretation, then you would still bill as we are today using the 93350 for the stress echo. And then for the components of the stress test itself, we would bill the 93016 and the 18. For observation and inpatient care codes, timelines are now published for initial observation and admissions. We have some time increments that are now assigned to them. Last year and in the past, if you look at the descriptions on the observation admit, there were no time limits associated with them. Now this year, we've got the same time amounts. The 99218 equals the 99221 equals 30 minutes. The second level of the admissions are now 50 minutes, and the highest level of the admissions are now 70 minutes. And again, this is observation, admission, and inpatient admission. We also have the subsequent care codes that are now having the same type of time limits. The subsequent observation code versus the subsequent care and inpatient, 15 minutes. Mid-level is 25 minutes, and the high level is 30 minutes. Now on these, a lot of us are familiar with the prolonged services. What they've started adding this year, it looks like, is that they're now giving us the same prolonged services in the inpatient setting that we had on the outpatient at the office. So on the codes, the 99354 through 99357, you can use these when a physician or other qualified healthcare provides direct face-to-face contact, and it also includes additional non-face-to-face services on the patient's floor or unit in the hospital. The 99354 and the 99355 is for the office or other outpatient settings. The 99356 and the 99357 are for prolonged services in inpatient or observation settings. So this can potentially increase provider reimbursement for hospital services. We have a play of words here on our AAA graft. In 2011, the description read endovascular repair of abdominal aortic aneurysm, pseudoaneurysm, or a dissection, abdominal aorta involving visceral vessels using modular bifurcated prosthesis, 2 docking limbs, radiological supervision, and interpretation. In 2012, the definition now reads endovascular repair using prosthesis of abdominal aortic aneurysm, pseudoaneurysm, or dissection, abdominal aorta involving visceral vessels, radiological supervision, and interpretation. So again, just a play on words. Be sure to read up on the description prior to coding. And lastly, we're going to go into the vena cava filters. And on here's just a description of a vena cava filter. These filters are to be used to prevent a clot from going into the right atrium. For these, we would insert these into patients that are at high risk of a pulmonary embolus and for patients who cannot be anticoagulated. The newer filters now can be repositioned or removed months later after an implant. And similar to implanting a stent, these procedures involve vascular access and guidance. The 37191 code is an insertion of an intravascular vena cava filter, endovascular approach, including the vascular access, vessel selection, radiological supervision and interpretation, road mapping, and image guidance either by ultrasound or fluoroscopy is used. Next we have 37192. This one is repositioning of the vena cava filter, and again it includes the vascular access, vessel selection, radiological supervision and interpretation, the road mapping, and image guidance. And finally, the retrieval, the 37193. And again, this one includes the vascular access, vessel selection, the supervision and interpretation for radiological, the road mapping, and image guidance. So these codes are now including everything that have been able in the past to be billed separately. On this, you would not report a repositioning with the new insertion, the 37192, the reposition, the 37191, which is the insertion. These are skin-to-skin procedures, including the catheterizations, vessel closures, and imaging, and etc. Here we have a new code for the abdominal CTA, 74174, the computed tomographic angiography, abdominal, and pelvis with contrast materials, including non-contrast images if performed, and image post-processing. The next three codes are not new ones, 74175 for abdomen, 73706 for the lower extremity, and 75635 is the abdominal aorta with runoff. Here you would not report the 74175 with the 737 or the 75635. For a CTA this year of the iliofemoral, you would report the 75635 with runoff. And actually, that concludes the training. If you have any questions, please feel free to contact myself, Sandra Renfro, Susan Price, or Sheila Michael. And here you also have the contact information of the email. I do thank you for your time and your patience with me today, so thank you.
Thank you, Sandra. We'd like to open it up for questions at this time. One of the things that we would like to encourage you to do as your billing company is always be aware of these kind of changes. We'll be looking at reports that will be generated based on the codes that are changing and are being deleted to compare what you did as a practice in 2011 so that we can get a better handle on how this might financially impact you going into 2012. And I'm hoping to have that done here within the next week so that we'll be able to go over that in your next meeting. It's important that not only you as the coders and the key people in the office operations side are aware of these changes, but also that the physicians are made aware of the changes. So something you might want to do is schedule time with your physicians to give them a copy of the handout and we will be making the presentation available to them online. Or, of course, we're always available if they want to call and speak with Sandra or Sheila or myself for any questions. So with that, I'm going to open up the meeting for questions. So go ahead and fire away.
No, I'll go then. I just want to clarify on the insertion of a new pacemaker. We're not supposed to use the code 71090 anymore. It's deleted. It's gone, right? So we report the 76000.
No, ma'am.
New insertions? No, not at all?
Not on the new insertions. What you would be doing on that, you'd be able to use the 76,000 code for any of the revisions if you're going to be changing out any of the generators.
Okay, so that's just on revision then?
Correct.
Any kind of
And
replacement?
the generator paint change out.
Okay, okay. I just wanted to make sure it's confusing to me.
Good question. Any other questions?
I got another one. On your observation codes,
Yes.
they put a time with that now?
They have, and there's other elements along with the H&P that would go along with the time increment. So it's not only billing by time, it's meeting the other criteria for the selections of the level of service.
Okay, so what our doctors turn in to us, do they need to be documenting time too?
It's always a good idea to indicate the amount of time spent because, again, the first one is a level of service. If you go over, if you're using the highest level of service for an admission or for a subsequent care code, if it goes beyond that time limit, we're now able to use the prolonged services. So that's just a standard, basically. You know, so again, if you're going over, let's say, the highest level of service of 70 minutes, and you're now going over, let's say, 30 more minutes, you can now use the additional prolonged services, and that's more money for the physicians and reimbursement.
And quite frankly, chances are the physician is already doing the time and has just never thought to document because that additional time was just always a given. So one of the things that we encourage is that you get back with your physicians and make sure that they know, even in a non-face-to-face evaluation with the patient, in that setting, they're spending time, for example, at the nurse's station reviewing the chart and looking at the prior physician's documentation and the outcomes of the patient that day. That time is now billable, whereas before it was bundled into one visit. So the prolonged is not only giving them prolonged billable services at the bedside, but it's also allowing them the non-face-to-face prolonged services that they are probably already spending, but they don't know that they can now be reimbursed.
So are the prolonged services billed along with the other codes or instead of?
No, it is billed along with the E&M services.
Okay.
Here's a good example of that. Let's say we're going to be doing an admission, and if you're looking at, or if you remember the CCU codes, that's a separate service there, that was billable in an ICU setting. So it was a higher reimbursement. So now what we can do, instead of it just being in the ICU, they now have the option for the inpatient settings is to go over the additional, or to use that additional time to their benefit and actually get paid for it.
Right, okay.
Good question. Anyone else have additional questions? I know it was a lot of information to go over in a short amount of time. So what we're going to do at this point, if there's no other questions, This will conclude the recorded session of the 2012 cardiology code changes.